Next, I invite Dr. Suma Unnikrishnan for her talk on traumatic optic neuropathy. She is presently the Associate Professor at Government Medical College, Manjeri. Over to you, Madam.
Thank you, Dr. Rekha. Good afternoon. So, traumatic optic neuropathy is an ocular emergency because it has got significant impact on patient's vision. Moreover, despite the mechanism is well known, the treatment strategies still remains controversial. So based on anatomy, it can be classified into the damage occurring at the globe, that is optic disc, that's called optic nerve avulsion. Then the intraorbital part, then intracanalicular and intracranial part damage causing traumatic optic neuropathy. So this can occur usually in the context of severe craniofacial trauma. Here, males are more affected in the 4th or 5th decade, and 8% of patients with traumatic brain injury will have TON. And the important fact is that 50% of moderate to severe traumatic brain injury will have a subclinical or undiagnosed traumatic optic neuropathy, which will later on present as optic atrophy or field loss. So there are two types as per the mechanism. One is a direct one, which directly affects the causing damage to the optic nerve, or an indirect one. The direct one is usually due to impingement by a bony fragment or foreign body in the orbit or intracranially, or by surgical manipulation. So in that picture you can see there is a transection of the optic nerve intraorbital part without any fracture. It is due to a direct injury. It can cause sudden and severe loss of vision, and the prognosis is very poor, but luckily it is less common than indirect one. And the indirect one is due to a blunt force to the ipsilateral temple or forehead, which is transmitted to the intraorbital and intracanalicular part of the optic nerve. So as you see in this picture, it is causing a very trivial injury in the forehead can produce traumatic optic neuropathy. Here also the vision loss may be severe and immediate, but it can also occur as a delayed severe vision loss. And pallor ensues usually after 4 to 6 weeks after the trauma. Coming to pathology, it is due to the dural sheath hemorrhage or interstitial optic nerve hemorrhage. It can also be due to optic nerve edema or shearing and ischemic necrosis, and hemorrhage occurs in 2/3 of patients in the optic canal, and 50% are associated with the sphenoid bone fracture. So after injury, what happens is that there will be acute inflammation and gliosis of the optic nerve, which can result in an optic nerve degeneration that will result in the functional loss of vision and eventual loss of retinal ganglion cells. So these are the clinical features you are all very familiar, that RAPD, reduced visual acuity, color vision defect, reduced contrast sensitivity, and field loss. Now, investigation of choice is a high resolution CT scan head, orbit, and PNS, preferably in the axial and coronal view. The 1 millimeter cut can detect the optic canal fracture and any bony fragments compressing the optic nerve. Then optic nerve hematoma, sheath hematoma or edema to be ruled out, preferably by MRI, but always rule out a metallic foreign body in that situation. Then OCT and OCT angiography can be taken later on to document the retinal fiber layer loss or ganglion cell loss. So these are some of the fractures as pointed out in the picture. This is a lateral wall fracture and sphenoid bone fracture. The other investigations are visual fields in awake patients and VEP, especially in bilateral cases when the pupillary assessment is very difficult or inconclusive. And this has also got a prognostic value. VEP, the less than 50% amplitude will have very bad visual recovery. But the fallacy is that when there is a concurrent brain injury, the amplitude may vary. That can also result in the reduction of the amplitude of the VEP. No field effect is pathognomonic of TON. Any type can occur. And the most common is the inferior altitudinal field effect, as you seen in this picture, because the superior part of the optic nerve is easily damaged, or early damage can occur because of this tight adherence of the superior part of the optic nerve in the optic canal. Though, as I said earlier, the management is very controversial. Because 30% can recover spontaneously, observation is one method. Then you can give corticosteroids or surgery or combined. And the indications for surgical management include intrasheath hematoma, foreign body, then compressive bony fragment, and if you document a progressive visual loss in the first 24 to 48 hours post-trauma. There are several treatment trials still going on, and the earliest one is the International Optic Nerve Treatment Study, which was done in 90s, and they concluded that there is no clear-cut benefit with either steroids or surgery, but a benefit if given intravenous methylprednisolone is given within 8 hours of injury. But after the National Acute Spinal Cord Injury Study 2, that also in 90s, they published that increased morbidity if the steroids are given in the spinal cord injury of more than 8 hours, and megadose steroids in head injury patients are associated with the increased mortality. Then after that, the CRASH trial came, which was published in 2005, that is corticosteroid randomization after significant head trauma trial. This was a very good randomized controlled trial in enrolling more than 10,000 patients of head injury patients. So they also concluded that corticosteroids should not be used in the routine management of traumatic brain injury, as they provide no benefit and may cause harm. And the latest trial is traumatic optic neuropathy treatment trial. This was also started in 2011 and the phase 1, and then 2014, that is phase 2, and in 18 they have started the treatment trial 3, and still it is continuing. And they published that they have compared, this is also a randomized control study, they compared that the efficacy of erythropoietin levodopa with steroid observation, and they concluded that these three, that is erythropoietin, steroid and observation, showed a significant improvement of visual acuity in patients with a TON, and initial visual acuity of no perception of light and late treatment of more than 3 days were significant risk factors for poor visual improvement. So what is the neuroprotective therapy is with the erythropoietin, which is a cytokine hormone, which is a hemopoietic agent, and it has got less side effects when compared to steroids. I have no personal experience of using this. All these are literature such. Now coming to the systematic review and meta-analysis, they have reviewed 3 treatment trials, the randomized control trial, which was published in 2024 June. They also concluded that there is no evidence of benefit for any medical treatment and strong evidence of harm from IVMP. Now, orbital compartment syndrome is a separate entity which needs surgery and medical treatment. What is the take-home message then is TON can result in permanent vision loss. Neuroimaging must be done in all cases, which is important medico-legally. And poor visual acuity and intracranial injuries predict poor visual outcome. So far, no definite treatment protocol is devised by ophthalmic community for TON. And various trials conclude that neither steroids nor optic canal surgery should be considered as standard care of treatment. And erythropoietin may be effective in some cases. But as per some Indian studies, which was published in Indian Journal of Ophthalmology, high-dose intravenous steroid treatment can improve the final visual outcome, but with caution in head injury patient. So in our institution also, we also give steroids, but not in patients with a head injury, always in discussing with the neurosurgeon. So in summary, the management of TON should be individualized, discussing with the patient and the relatives, and case-by-case basis. So to conclude, no scientifically proven treatment protocol for TON. Timely diagnosis is important medico-legally. In head injury patients, treatment with IVMP needs caution, and more RCTs are needed to set a new treatment protocol for TON. Thank you for your attention.
Thank you, Suma madam, for that wonderful talk on